Hey friends, welcome to 1 Minute with Monee. Balance doesn't happen overnight, but it does happen one intentional minute at a time. This podcast gives you the tools to make it happen. I'm your host, Monee, your favorite concierge and founder of Time Managed LLC. Join me each week for practical tips and real examples to help you manage your lifestyle with ease. Hello and welcome. We are kicking off season 4 of 1 Minute with Monee. Can you believe it? We are on episode 48, and I am so excited to welcome Dr. Amaka Eneanya. She is an award-winning nephrologist and healthcare executive, and we're going to talk all things about health disparities, kidney disease, and some myth busters too. We'll have a little fun. Welcome. How are you?
I'm doing very well. I'm so excited to see you. Thank
Yeah.
you for the invitation. This is awesome.
You're welcome. We've been friends for a minute,
hmm
and I've just been blown away as I've gotten to know you a little more about all the things that you've done. And it's so interesting how you do have friends and people who you know fairly well,
hmm
and then you're just amazed by, like, oh, you did
Right,
that?
right.
And so I would love for you to share. How did you find this particular niche in medicine and a little bit about your background?
Sure, sure. I think when people say stuff like what you just said, like, I didn't know that you did it. I think it's because, we're all layered and I feel like
Mhm.
it's also part of my calling to do what I'm doing. So maybe I don't talk about it as much as I should, I need to get the information out there. So I'm glad to be sharing it with you. But I do feel like I've been called to help, people with kidney disease, in particular, Black people with kidney disease. There's a ton of disparities. And when you asked about my motivation to do this career, that's really what it was. So just to kind of rewind, I'm from Pennsylvania. I grew up outside of Philly, and I come from a family of physicians. So my dad is also a kidney doctor, a nephrologist. I have 3 brothers. 2 of them are physicians, and my youngest brother's a scientist. So we all kind of grew up having like dinner talk about medicine, and my father being a kidney doctor, someone who we would visit in the hospital, do rounds with him. It was always a big influence for all of us to pursue medicine. So, it's also that we're Nigerian. And so there's a joke that Nigerians don't really allow their kids to do anything besides medicine, science, or law.
Okay.
So there's that too. So we all pursued medicine really because it was ingrained in us, right, to do one of those 3 careers. But when it came to choosing nephrology, I was in residency, I remember, because I started off wanting to do women's health. And the reason I wanted to do that was because my mother passed away from the complications of childbirth. So when she had my youngest brother, I was 12, and she had what we call a pulmonary embolism or a lung clot. So she passed away. So at that age, I thought I wanted to pursue medicine and really study women's health. But when I was in residency in Boston at Brigham and Women's Hospital, I was doing a lot of intensive care unit rotations, and I just kept seeing a lot of Black patients on dialysis in the ICU. And it was just interesting because like the ICU rooms are very small and Black families are very large, right? And so they were just all crowded into this ICU room. And it was just profound for me to keep seeing so many people pass away from kidney disease, so many family members being confused, like, how did we get here? And I just vowed at that moment, I was like, it clicked. I'm like, I'm supposed to be doing something in this space to help my people. That is what pulled me away from women's health to do nephrology. And it was, my dad had an influence, but that was really it was the patient population in nephrology that really drew me to the space.
Okay, nice. Was he really excited when you told him?
Oh, yeah. It doesn't hurt that I'm a daddy's girl too. So he was
Oh,
like,
yeah.
hey,
'Cause you're the only girl. You said you have
I'm the
what, 2
only,
brothers,
no,
right?
3
3
brothers.
brothers. Yeah, so I
Yeah.
can imagine
Oh,
how
he's
he
super excited.
felt.
Oh, he still is to this day.
You're
Yeah.
definitely his favorite, I'm
Yeah.
sure.
I mean,
It's
I'm not
debatable,
gonna say it out
right?
loud.
I said it.
Yeah,
You don't have to.
yeah.
Now take me through a little bit more of your career because there was a point in time where you switched from maybe seeing patients, and please correct me if I'm wrong, but maybe
Mhm.
seeing patients doing the research to then becoming an executive.
Mhm.
Talk to me about that transition.
Yeah, so that's been a journey. And so I went to a very academically centered training program. So I went to Brigham and Women's Hospital, which is a Harvard teaching hospital, one of Harvard's main teaching
Mhm.
hospitals. And then I did my fellowship in nephrology with additional 3 years in addition to the 3-year internal medicine residency. So it was very research heavy, right? And most of my colleagues at that time, I did my fellowship at Massachusetts General Hospital, and then I was faculty at Massachusetts General Hospital, which is another Harvard teaching hospital.
Okay.
So I was an academic nephrologist full stop, right? I was doing mostly research, and my focus was on how people made decisions about dialysis, in particular older individuals, because the literature at that time was showing that like dialysis may not be right for everybody, right? It may not actually extend the life of everybody that gets put onto it. And I was really focused on health inequities because Black people tended to be on dialysis significantly more often than other racial groups, in particular white people. So I was studying like that decision point of when you had to make the decision about dialysis, like were people understanding all of their options, or if they were too sick, were they being told that? And that was like my jam for many years, right? Like close to 10 years. And then it wasn't until the pandemic, I was doing this decision making research. I was also focused on end of life care, another topic with huge health inequities, Black people tending to get more aggressive care in the hospital. So in particular, like I was focused on those those dialysis patients, and kind of figuring out, why do Black people have to die in the hospital when it's been proven that that does not help your quality of life. In fact, it takes away from your quality of life and what they call your quality of death. So I was focused on that space. And it was the pandemic that really just like shifted everything in my career, because one, I moved from Massachusetts General Hospital in Boston to Penn Medicine in Philadelphia. So my family's from Philadelphia. And at the time, my family member had some illness. And so I wanted to be closer to my brothers, my father, et cetera. And so I took that research with me to Penn. And when I got there, we learned that some Harvard medical students, I mean, like I had just left Boston, right? Some Harvard medical students were kind of making a lot of noise about one of the algorithms or one of the clinical tools that we use in nephrology to diagnose or manage kidney disease. And it's called an EGFR equation. So people are like, what is that? Right? So I'll make it real simple, but it's on your lab test. If you ever get labs in your primary care clinician, if you're with your primary care visit every year, you'll see something called EGFR, and that number tells us how well your kidneys are working. So if you see the number 60, the way that I would say it to a patient is like your kidneys are working at 60%.
Okay.
And so for a very long time, there were two EGFR numbers. There was one for Black people and one for everybody else. I know.
Really?
I know. Yes, it was just like that. I mean, it was
Okay.
like that in med school, right? It was like that in my residency. The thing about it was when I was in Boston, I didn't see the two numbers. I just saw one, and you had to go calculate what the Black EGFR number was. So I never did it, right? I was like, I'm not doing this. But when I got to Penn, well, it was listed. It was like Black EGFR, non-Black. So it was like in my face. And as soon as I got to Penn, I had some colleagues in my department that were like, we got to write about this. This is wrong. And I had heard about the students in Boston who had completely thrown out that equation in one of the Harvard hospitals. And so I was like, we got to get up on this, right? Like we're nephrologists. And so we wrote about it in one of the very highly ranked academic journals, JAMA, and it went viral. And at that time, I had been trained in a media course in particular, and I learned how to tweet. So I used those skills, right, to like make it go viral, and it just went viral. And I actually like was like, okay, we're good. Like, close the book. And I became that person overnight. That was the expert. I actually was intimidated. I was like, wait, I'm a palliative care researcher. I study decisions, right? Like clinical decision making. So I don't know this space as well. Like the EGFR space is basically a statistical equation. So it is much different science than the science that I was used to, which was like interacting with patients. It wasn't mathematical kind of things, but I did have an MPH, so I figured it out, right?
Yes,
I
yes.
learned, the science of EGFR equations because shortly after I published in that journal and it went viral on Twitter, I started getting national talks. And I was like, me? They were like, yes, you. About, why it was wrong. And so long story short, that was a huge battle that we had to take on to remove that Black equation. And the reason that we were fighting it was because it would make Black people appear healthier than all other racial groups. And so, depending on the equation that was used, it would make it seem like Black people had 16 to 21% higher kidney function or better kidney function, which means that you had to wait longer to see a specialist like me, longer to get a kidney transplant, where there are already significantly wide health inequities when it comes to Black people not being referred early, not getting kidney transplants, right? And so we had to fight the academy to change this. And when I say fight, I mean fight. Like there were a lot of people that did not want to make this change. It was not a
Mhm.
costly change. It's basically going into a lab, any hospital lab, any clinic lab, and reprogramming the statistical equation to remove that black variable, black race variable in it. There's
Mhm.
a number of variables in the equation. So it was very eye-opening, and that is what inspired me to make the shift to leave the research, leave the academy, right? And to stop being an operator in the healthcare system and try to change the system, right? Like try to actually be an administrator, be an executive that can like focus on the policies or the equity and ingrain that into our healthcare delivery system. That is when I made that switch. It was in 2022.
So not too
Yeah,
long
not
ago.
too long ago.
Do you know the reason why that was even added, that variable was even added to the equation? Because it sounds like it was, I don't know, miscalculating the true health of the patient. And so you mentioned that 60 number. So maybe
Mhm.
if the number was 60, they'd add 20
6
points and say that it was at 80 function when really it wasn't.
Correct. Yeah, absolutely
Okay.
right. They would add like 21% or depending on the equation, 16 to
Mhm.
21% higher. And so black people were being told you're fine
Right. And what
because, and it goes back to slavery and racism. For a
Mhm.
very long time, people were taught, all of us were taught in medical school that black bodies are different, Native American bodies are
Mhm.
different. So when we would learn about disparities, black people having more stroke, heart disease, kidney disease, it'd be like, well, they're just predisposed to disease. They have predisposition to to getting I'm not making it up. And so the actual study was really focused on statistical accuracy. So when they put in that black race variable using statistical performance metrics, they were like, oh, it's actually more accurate. So but then it was when it was time to explain in the actual research article why they did it, it was like, oh, black bodies are different, right? Like, this is why we're going to add this variable to account for black bodies being different. I could get real technical about exactly what they said was different, but I
Mhm.
think it's just going to confuse people. But long story short, they said black bodies are different. This black race variable is going to make the equation more statistically accurate when used among black people. So that is where it was coming from. Now, they made up that part about black bodies being different because there's literally no research anywhere in the world that we're just born biologically different, right? And in
Mhm.
fact, the Human Genome Project that came out of our government study said that in 2003 that we are more alike in between racial groups genetically than we are within racial groups, right? So you and I look extremely different compared to maybe a white person or a Native American. We may look more similar to those racial groups.
Mhm.
There's really no basis for them to
Mhm.
have said that.
Right,
Yeah.
right. That's maddening because I also think
Mhm.
about how another initiative, and we won't go into more detail, but I think it's worth mentioning is our pain tolerance. And
Mhm.
so when you think about women complaining in childbirth about their pain levels or that something's going wrong, and then you have the high mortality rate for Black women in childbirth.
Mhm.
And a lot of it is because they're not listened to, because
Exactly.
in the mind of maybe the nurses, the doctors, they're like, "Oh, they're okay.
Mhm.
Their tolerance for pain is higher," or they may not be telling the truth. So I think all of these things are related and
Mhm.
that the perception is false, and it
Mhm.
leads to higher mortality rates in certain respects.
Absolutely. I mean, it goes even beyond kidney disease or pain tolerance. There's actually race baked into many tools. There was one for vaginal deliveries, right? And in terms of black women or other minority racial groups having a vaginal birth after cesarean section, there's actually a tool to calculate, is it appropriate or is there a high risk of having a poor outcome if you do a vaginal delivery after cesarean section? And it was saying that for black women, like that black race in that calculator was saying that black women shouldn't have the vaginal birth. And we know that vaginal births are safer,
Yep.
right? Better outcomes. So it's actually baked in multiple aspects of healthcare that people have been putting in race, whether it's Asian race, black race, right? It's not, or Hispanic ethnicity. It's in a ton of statistical tools. And again, people have really focused on accuracy without really thinking through, well, why would this data look different in this racial group, right? And really going through that theoretical basis, or even maybe not putting it in the first place
Right.
because we know that we're not different, biologically. between racial groups.
And
Yeah.
there's no room for bias when you're trying to take care of someone.
You
Oh,
would think
you
so.
would think so. You would think so.
Yeah, not
Wow.
the case.
So 2022, you've
Mhm.
gone viral, you're making waves in the
Mhm.
industry and specifically with your research. Then what? When do you move to Atlanta? I want to get to the good
Oh,
part.
you wanna jump to
No, you don't have
Atlanta?
to jump, but what happened after
So after
2022?
2022, I left Penn Medicine and I joined a global dialysis company called Fresenius Medical Care. It's the largest global dialysis company in the world. There's 4,000 dialysis clinics. And I was like, wow, what impact, right? Because I was like, I don't want to be writing papers anymore because they just get stuck in the academy and only, academy people read it, only clinicians and researchers read it. I want to go global, right?
Mhm.
And me, selfishly, I was thinking like, so my family's from Nigeria. I'm like, I want to bring dialysis to Nigeria. Like there's no, like the whole global map for Fresenius is absent in Africa, with the exception of Morocco and South Africa.
Okay.
They didn't have any clinics there. So in my mind, I'm like, I would have huge impacts.
Mhm.
Not the case, right? Like a global organization like that. I was the head of strategy and operations in the global medical office. So I was doing patient experience. I wrote the whole strategic plan for health equity for the organization. I was looking at some finance things. I was really learning the business of medicine. But I think it was a little naive of me to think that I was going to go and just like completely change that entire global business strategy and bring dialysis to West Africa. They were like, yeah, no, we're not interested. And in that time, they were actually doing a significant reorganization to save money. So they especially were not trying to expand at that time.
Okay.
So I was like, okay, that's great. So I got my MBA right during that time and like, practicing the business of medicine, learning how to manage, learning how to really think in a systematic way. When I got the call from a mentor who had just accepted a position at Emory Healthcare, and he said, I need you here. I need you to bring your way of thinking and the way that you transformed medicine by fighting the good fight when it came to the EGFR equation. And we can get to what happened with that because it was very successful, that fight. And he's like, and I need you to bring the business of what you've learned at Fresenius Medical Care, and I need you to be the inaugural chief transformation officer, where you're going to be standing up brand new functions or significantly revamping functions that need help. And at first I was like, really? Because I hadn't been at Fresenius very long. I'd been there just about a year.
Okay.
But I'd known this mentor for 15 years. I knew him in Boston. We were very close. I trusted him, right? And so I said, after my third interview coming down here, I was like, actually, it's actually pretty cool down here. I think I can make some change.
Yeah.
So that's how I got to Atlanta. I was recruited to do just that work, was to kind of revamp things at Emory Healthcare, things that were deprioritized, like really bring them to the surface, make them a priority, build teams. Health equity didn't exist, for instance, like built that entire team to improve community engagement, things like that.
Okay.
Yeah.
Well, good. We're definitely happy to have you in Atlanta.
Thank you.
So tell me more about the outcome of that new calculation. You said there was more.
Yeah. So we were successful, essentially. And I'll just tell you the strategy. We had to do what's described in the business school literature in terms of how you transform large organizations, right? Or how you really think about leadership. But because we had very powerful people, and I mean like CEOs of hospitals and healthcare systems, full professors, people who are on the like honor societies of academia, really trying to stop us, we use social media as a tool. We had a lot of students, what we would say are frontline kind of fighters, students, medical students, residents, people who were challenging their professors. I mean, it was extremely effective, just very similar to like organizing in the civil rights movement, right? And so it wasn't just this powerful kind of concentration of people at the top. We were using every tool that we could, and social media was a huge tool too. So everything that we published went on Twitter, went on Instagram.
Okay.
And then the big outlets started to pick it up. New York Times was the first outlet to reach out to me. And I said, excuse me? And they said, we want to highlight your work. And they featured me prominently. Next thing I know, Consumer Reports was coming and other big outlets. Since I was on NPR, I was on the Doctor's TV show doing an interview. And then Shonda Rhimes' team saw me on Instagram, and specifically, so I helped them with episode for Grey's Anatomy, season 18.
Okay.
Episode
No, I am a faithful fan of Grey's Anatomy and Shonda Rhimes. That is exciting.
Yeah. remember when I jumped on the call with the writers, I was like, okay, I have 2 asks. Can I meet Shonda? They were like, no. I was like, can I be in the episode? They were like, no. I said, okay, let's keep going. So, and they did a really good job. And I'm happy to send you the clip too, or just even watch the whole entire thing. But we made a lot of waves, right? And at the end of the day, that led to our largest societies in the kidney space, American Society of Nephrology and the National Kidney Force, forming this task force to really move forward in terms of what are we going to do. I was on that task force. I can tell you it was extremely contentious. It was not fun at all because some of the main people who were leading those national task force did not want to change. So they were manipulating the meetings in a way to not, and in retrospect, I think, was that task force set up to really just maintain the status quo? Because besides myself and like one other person, we were outnumbered. It was extremely painful. Wow. It was one of the most difficult things of my life. Regardless, we were still doing a lot of that organizing. Students were writing petitions, challenging their institutions, all the social media waves. And then I was honored to be an author. Like the original authors who actually developed that equation with Black race wanted to work with me. And for that, I'll be forever grateful because they had a lot of data that I didn't have. Again, I was doing different research than them. So they invited me to be a second author which is like a big deal in medicine. If you're first or second author on a big paper, so on the New England Journal paper, where we published a new equation that did not have Black race in it. Spoiler alert, it was just as statistically accurate as the initial one. Of course. So at the same time that paper was published, then the task force, the American Society of Nephrology and National Kidney Foundation task force published recommendations to use that, immediately implement that new, what we call race neutral equation that everyone can use regardless of race immediately. And then as that was happening, I was very busy. I was also on the Minority Affairs Committee for the United Network of Organ Sharing, which is the kind of the government subsidy that manages all solid organ transplants. So they have a Minority Affairs Committee, and we developed 3 policies at that time to basically ban the use of any race-based equation for kidney transplant listing. The second policy, which I call the reparations policy, basically required every single transplant institution in the United States to go through their wait list. There's about 100,000 people on the kidney transplant wait list every year. Go through their wait list. Every Black person had to be reviewed. And if you use that new equation, and they really should have been, let's say, higher on the list, they got moved up. Okay. So as of May of this year, 23,000 Black people have been moved up on the list. Average, they've been moved up about 1.7 years, and almost 10,000 Black people have gotten kidney transplants since that policy. My dad being one in January.
Oh,
yeah,
my
he benefited. He was
goodness.
like my inspiration the whole time. So he was listed. He got moved up 18 months. So it was nice to have that come full circle to my family.
For sure.
So, and that was really like my inspiration to keep fighting, because multiple times I wanted to quit. I was being bullied, it was just, and I think there was probably some sexism and racism involved as well. And then the third federal policy, there was actually another tool that wasn't really being spoken about, but it was the way that we grade the organs from people who die. So if you're a kidney organ, if you check that you want to donate a kidney organ on your license, there was actually a tool that was grading the organ as less quality if you were Black.
No way.
So the third federal policy, so that means that the organ was more likely to get discarded, thrown out, and not used if you were Black. So the third federal policy changed that tool as well to remove race. So there's no longer any risk of that organ being discarded.
Wow. All of that is amazing.
Thank you.
Like, congratulations on all your hard work and
Thank you.
sticking in there.
Oh, yeah. I have a good therapist.
And you have to, I'm sure. But your work is not finished. There are still disparities happening today, even some legislation or some federal policies that have changed. Tell me more about that and what you're doing to kind of pay attention to what's happening, and what would your reaction to those things be?
Yes, I figure I actually have come at this big age. I've realized that, I'm not one to, if I have to ask multiple questions and I don't see anything done, then I'm like, I'm going to do it. That's what happened with the EGFR and race equation, right? And that's what's happening now. So my big thing now is there's 37 million adults with chronic kidney disease in this country. It's been like that for over a decade, and only 10% of people actually realize that they have chronic kidney disease. Now, on the other hand, there's about 800,000 folks that are on dialysis, so that have complete organ failure and need dialysis. All of the attention of the healthcare system is on that 800,000 people, right? The financial incentives, right? The insurance companies reimburse, and everything is based on that skewed, end stage population. And I'm like, what are people doing about the 37 million adults with what are we going to do? And the
Yeah.
guidelines are the same. So what they say now is that primary care needs to manage chronic kidney disease until it gets to a certain severity level. Then you refer to someone like myself, right?
Okay.
The issue with that is that it's become like a hot potato. We know that number one, there's a huge shortage of primary care physicians in the United States, and it's just getting worse, right? Primary care physicians have to do pap smears, screen you for depression, make sure you're not smoking, check your cholesterol, blood pressure. Like the laundry list is so extensive that kidney disease, for the most part, is not a priority. And I'm going to generalize here, but it's not a priority for a lot of primary care physicians. And I know that because the patients that would come to me would be like, no one ever told me, ever, right? And so I'm challenging the healthcare system to say, listen, maybe nephrology needs to, shift our focus away from that very sick kind of late stage disease course and shift up towards the preventative side. And so I've started a new clinic. It's a direct specialty care clinic, and I'm testing out this model. The researcher in me is just curious, like,
Uh-huh.
how is this going to be? And it's actually a model of care that's become very popular, especially in Atlanta, this direct care model, which is basically no insurance, right? It's self-pay, cash pay. It doesn't have to be expensive, right? There's a range of prices, but what it's really done for clinicians, one, is that they don't have to see like 40 or 50 patients a day just to make a good salary. And they don't have to rush. And that's the biggest thing. I think the way that insurance reimburses visits, it's making all of us rush. People are not getting the care that they want.
Yeah.
The wait times are huge. Even though they're seeing a ton of patients, we can't
still
keep
have
up.
to-
So this model of care is really disruptive because it allows you to have an hour with a patient. The patient can text their doctor, right away if they have questions. You can talk about things like nutrition and, how is obesity affecting my kidney disease? And that's going to be the focus of my new clinic. And it's called Bold Nephrology
Mhm.
Direct Care. The bold stands for better outcomes, less disease. And I think it's just true to who I am. It's bold. I'm the first in
Yeah.
Georgia, first in Atlanta to have this type of direct specialty care. It's very popular in primary care.
Mhm.
And I want to see, does it really improve patient satisfaction? Does it improve outcomes in terms of preventing chronic kidney disease? There's a ton of FDA approved medications for chronic kidney disease. People are not on these meds. They don't know they have it, and they're not on the meds that are going to prevent them from progressing to dialysis or needing a transplant.
Mhm.
So I'm going to be really focused on that prevention side, explaining things, personalizing people's journeys. And that is why I'm starting that direct care space. I'm really excited too.
I'm excited for you.
Thank
Yeah,
you.
congratulations.
Thank you.
When you talk about the disparities or even the number of people who like have kidney disease and may not know it, walk me through what that would look like for just an everyday person. So take myself for instance. Like how would I know to pay attention to my body in a way that would make me need to come talk to you? Or is there something in my lab work? Like what is the process that I should go through to then evaluate what I should be doing differently or when it's time to come see you?
Yeah, it's a great question. And I've been doing some short form education on TikTok at Amaka EMD. If you're on TikTok or Instagram, it's the
Uh-huh.
same name. But I'm really challenging patients. And we always were trained not to put the onus of things on the patient. But I just think our healthcare system is in need of transformation. So I'm empowering people with the questions and tools. So let's just kind of rewind as to what contributes to chronic kidney disease. So the number one cause is diabetes, like full stop. That is the significant contributor to people's kidneys failing over
Mhm.
time.
Mhm.
The number two cause right after that is high blood pressure. So if anybody has either one of those diseases, you're just not aware that poorly controlled or poorly managed high blood pressure or diabetes is like beating up your kidneys, like silently all day, every day. And your kidneys' job are to clean your blood of toxins extra fluid. That's what your urine is. It's extra toxins and fluid that comes out every day. You don't even know that it's doing that. But the diabetes and the high blood pressure is just nicking away at your kidney's ability to do that efficiently. And so that is what I typically see. So the first things that you're going to see, the first sign of kidney damage is protein in your urine. Now, we all have protein in our bodies, natural proteins, and the kidneys have a very complicated way of just like holding the proteins in your body. So when your kidneys start to fail, they start to spill those proteins out of your body into the urine. So one of the big things that is recommended, especially for people with diabetes and high blood pressure, is to check your urine protein.
Okay.
That is a very first sign of kidney disease. Again, often that's not even checked, so people don't know. And then the next stage, because there's stages of chronic kidney disease, and I won't bore people with all of those kind of minute details, but is when your blood tests become abnormal. And the two tests that we look for are something called BUN and then creatinine. And so if you have elevation in those biomarkers, that's letting us know that your kidneys are not getting rid of those toxins the way that it's supposed to. So it's building up in your blood.
Okay.
And that's when you check your blood levels, those numbers are elevated. And then obviously EGFR, like I said, is that way to kind of calculate how well are your kidneys actually functioning. So anything less than 60 is called chronic kidney disease. And so those are the things that people need to pay attention to. Unfortunately, we have guidelines that say that you should see a nephrologist very late. These are international guidelines as well. So the guidelines say that you should see a nephrologist when your EGFR is less than 30. That is what we call severe chronic
That
kidney
seems so
disease.
low.
Exactly. Do you see why I'm challenging by trying to do more preventative care? And so when people are told that they're fine, it's because the primary care physician is like, well, you don't have to see a nephrologist until, you get more advanced, you're fine. Right. And I think it's a disservice to patients to be told that they're fine when they have a part of their organ that's not working properly. And so I think if anyone sees protein in the urine or your BUN, creatinine, or EGFR blood tests at, not being normal, the first question you should ask your clinician is, hey, what are we going to do about this? What do you think is causing it? And if they can't answer that question, you should say, do you mind referring me, or could you refer me to a nephrologist so I can just get more information about this? That is what I think people should do.
Okay. They'll come find you at that point.
That's right.
So from the beginning, the normal blood work that your doctor gives you, if those metrics are not a part of what they're already doing, is that something that most doctors are open to adding to that list, or is it standard?
It's pretty standard.
Okay.
You'll get your cholesterol checked. I'm sure you've had your cholesterol checked, and they'll usually look at see if you're anemic. So they'll do something called a Chem7. That's a basic metabolic panel that will have that BUN and creatinine in it.
Okay.
I think if they're not checking it, and if you have a family history of kidney disease, high blood pressure, or diabetes, I think that should be a question like, hey, can you check my blood and urine tests to make sure that I'm okay? Because unfortunately, there's really no symptoms of kidney disease until you get to the very end. When I say very end, I mean the EGFR number is usually less than 10. So imagine going from 60, nothing, right? Then you get down to like 9, 8. That's when you start to feel really sick, right?
Yeah.
And so unfortunately, it does take a lot of education to empower people to say like, hey, these labs are off. These numbers are off. Like, what can I do? How can I make sure that this doesn't get worse? Or what do you even think is causing it?
Yeah, I love that word empowerment, because I think that is what we need in every aspect of our life, right? When we're thinking about our wellness, how are we empowered to speak to a therapist, to advocate for ourselves in certain situations at work, to go into a doctor's office and say, I know you're not looking at this, but this is what I see and understand. Now, what do you see, or what are the things that you think I should be doing differently? Just having those conversations and not leaving it up to your practitioner to make all of the decisions for you.
Absolutely.
Be curious, ask good questions. And there was one question that when I was in grad school, one of our it was a data class, and one of the professors said that every time he goes to the doctor and there's something wrong, the question he always asks, is this the first time that you've seen this? What else could it be? And have you ever seen anyone else with these symptoms? So not just leaving it up to them, but really being curious about other things that could be happening,
I love
because,
those
you
questions.
can't just come into the doctor's office and leave and take what the doctor says at face value all the time, I think is what I'm getting from that.
And I think that's a great point, because like I said, the way that insurance, structures these visits, they have 15 to 20 minutes to cover a lot of ground. And let's say you're having a backache, right? Or your back has been hurting you. That's going to take precedence over some mildly abnormal blood tests, right? So they may not get to that. Like they're focused on like treating your back pain and making sure that you're okay because that's what you've brought to them. So I think, it does take some education for you to be like, hey, my organ is not working.
Could be something else.
It-
knows, right. So one of the posts that made me reach out to you to talk about this is I think you asked, how much do you spend or do you take electrolytes? I don't know what
That's
it was.
right. That's
but
right.
Yes, I do.
And I said, why do you do that?
So what prompted that question? And what is it about electrolytes and maybe even other things that we do that we think are beneficial for our bodies? What made you ask that? And
yeah, I think I don't know. I think I had read something that morning in particular. There's what we call the longevity movement, right? Like there are a lot of influencers, not necessarily clinicians or people who are trained, that are putting it out there to do certain things to make sure that you live a long and healthy life. And a lot of this stuff has no research or evidence basis. So maybe I'm a little biased. I need to see, like, show me the clinical trial, show me the paper where this stuff is actually like good for you. And so I thought about in my field, what I see a lot, and this is even amongst my physician peers. So I'm not judging anybody here, but a ton of people take electrolytes. So in addition to what the kidney getting, filtering your blood of extra fluid and water, it's also tightly regulating your electrolytes. So sodium, potassium, chloride, phosphorus. It's like getting rid of those things in the urine, like very finely tuned, and keeping some of those things in your body. So if you were to, take electrolyte, I don't even understand why people do it. Just in my mind, people say they feel better. I personally feel it's placebo, because if you put anything extra, like I said, your kidney is tightly regulating everything. It detects a little bit of high potassium, it's going to pee out that potassium, right?
So it's not even, your body's not holding on to it if it doesn't need it.
Correct. So if you're putting things that are what your body seems as excessive, or your kidneys are detecting as excessive, because they're going to be like, wait a second, that's not, that's not being regulated in the way that I'm regulating it. Let me just pee it out. So I just, the times that electrolytes are appropriate, we'll just go over that, is if you're doing vigorous, intensive, exercise, you can sweat out a lot of electrolytes, sodium being the main one, but you can sweat out chloride, potassium, all that comes through your sweat glands. Or if you're having a lot of diarrhea, that's another way that electrolytes will come out. So people sometimes, depending on if they have any GI issues, are like, I go to the bathroom, like I have like 5 or 6 bowel movements per day. It might be more appropriate for you because you're losing a lot of excessive electrolytes. But for the average person that's eating like a pretty balanced diet, right?
Yeah.
You don't need, you're getting those electrolytes from your food, right? And so I personally feel that like electrolytes are a significant waste of money, but I have people who say that they feel so much better when they take it. I have strong feelings about water as well, bottled water. I feel like water is free. I feel like, again, your body does a lot of regulating in terms of getting rid of things that are not supposed to be there. And I think plastic in particular, and I learned this when I got my master's in public health, just how dangerous plastic is to your body. So storing water in plastic, like plastic can seep things into the water, especially if you like have it out in the sun all day or in a hot car. It is seeping chemicals and toxins into that water that are just not safe. So I'm always a fan of tap water as well, but that's just my opinion. You can take it or leave it.
No, thank you so much for enlightening the people. I mean, we get
tap water all the time.
Listen, and I am not afraid to speak my truth.
Okay, all right.
So, no, but I think I do agree or can relate to what you're saying. I mean, I'm no doctor, obviously, but I exercise a lot. I've done up to half marathons in training. And so even when I was working with the trainer, she was telling me, don't take Gatorade unless you have had at least 45 to 60 minutes of physical activity and you're sweating, because then that Gatorade will kind of replenish what your body has been depleting. So I think it checks out, right? I think in some respects,
I mean, I didn't even know that person. I didn't even know that person. I mean, it's the same thing. Yeah.
I think the knowledge that you're bringing is valuable
because thank you.
You see it in Sam's and Costco when they go on sale, and there's like the liquid IVs and things of that nature. Like, we are buying it, and there's so many things in our society that are marketing ploys that make us spend more money, and so I
And
don't.
I wish nephrologists would speak out more about it. And I've seen them do it, especially when Twitter was hot during the pandemic. There was much more nephrology as a field was very active on Twitter, because there's one particular like famous nephrologist that's like huge on Twitter. But since Twitter has not been as popular, I don't see that being put out into the atmosphere. That's why I'm trying to do more education.
Threads.
Yeah,
Threads.
Threads.
I feel like Threads is the new Twitter.
It's a little bit of a different vibe.
Okay.
Twitter got really academic during it was really a good source for many things, not just academia, but like journalism, right? It was just a source of accurate information. Threads is a little bit of that. It's also pop culture, right? But it can reach a lot of people. But I posted that because I was particularly like, let me see something. But again, I have physician friends, like people who did the same exact, training as me in terms of learning what the kidney does, the pathophysiology behind it, that swear by it. So it's just, when you get it to your head, that it's going to make you feel better. Okay. That's called the placebo effect. Yeah. Yeah.
The other thing that you mentioned is alkaline water. Have there been studies about the impact of alkaline water?
There's not studies about any of this stuff. Yeah.
So mind-blowing, because you hear over and over that disease can't survive in an alkaline body. And so drinking the water will help to, I guess, normalize those levels in your body. What do you think about that? And how does that...
No. So the other thing that the kidney does is super cool. This is one of my favorite topics in medical school is acid base. So everybody has acid in their body, and the kidney regulates the level of acid. So if you ever have a urinalysis, let's say you may think you have a UTI and they check your urine test, they'll check the pH of your urine because your kidney is tightly regulating the pH of your blood. And so bicarb is one of the base kind of chemical molecules in your body that the kidney is regulating. So alkaline was like all of these things, again, like your kidney's already doing it. Again, if you don't have a very balanced diet, maybe, right? If you're losing things through your GI tract, either nauseous and vomiting or diarrhea, or if you're intensely sweating, I think those are all good kind of reasons why someone would be like, okay, I need to do this, right? I think, but outside of those examples, your kidney is going to be regulating the alkaline nature of your blood, the acidic nature of your blood, right? That's the balance between acid and base. And your kidney does that.
Tested?
I mean, the testing that I've seen with alkaline, which is to me bicarb base, right? A chemical base, is like in the ICU. So people who get really sick, and I love ICU medicine. I did a ton of moonlighting. I've considered actually doing a fellowship in critical care medicine. And the reason I liked it because they every hour get every single amount of data in your body, your vital signs, all of your labs, right? It's just, there's all these numbers. So you can just see how finely tuned the body does things, right? So when people are really, really sick, the levels of acid goes very high in their blood. And what we would give in the IV fluids is bicarbonate. And then it would just, people respond beautifully to that. So if your body is off in terms of the acid and the base level, right? The alkaline or the acidic nature of your blood, you will be very, very sick, right? And that is when it's appropriate to either give more, base to neutralize the acid. Acid is very dangerous for your body. People die. People code all the time. Diabetes, if your sugars are not controlled, the acid goes way up. That is when you give bicarb, people respond beautifully. Outside of that, the drinking, trying to put, things in the water to, regulate the acidity of your blood or your body is doing nothing. I said what I said, and people can challenge me if they want. I said what I said.
We'll see what the people say, but
yes,
I'm open. You're the expert, and that's why you're here, so I can learn more.
There was a time when all of these things didn't exist. Let's just put it like that, and people did just fine.
For sure. Are there any other myths that we should know about before?
I think we covered it. I think the ones that really get me going are electrolytes and bottled water. I can't see myself purchasing things that are free or that your body's already regulating.
Okay.
So yeah.
Well, let's talk about the future of like
Yeah.
nephrology
Yeah.
and I don't know, AI technology. What are your thoughts around the future? And it sounds like you're contributing to that future. So is there anything else that we should know or think
Yeah.
about?
I think it's a very difficult time in healthcare right now. I think people are burnt out. I think people have lost insurance because we know that there's a number of changes with Medicare and Obamacare and subsidies going away, right? Like, so people are in a very vulnerable state health wise. And I think the repercussions of that are coming, right? I think people are going to be very sick. They're not going to focus a lot on preventative kind of preventing diseases or preventing the diseases that they already have from getting worse. So I am a fan of, again, really empowering yourself to know, what can I do to make sure that I'm healthy and safe? There's a ton of information on there. What I would do is to recommend that people go to experts, right? There's influencers that have millions of followers. That doesn't necessarily mean that they are putting out the right information.
Yeah.
So I think really checking the source of who it's coming from is very important. When it comes to the direct care space, I think that is a space that until we have Medicare for all, right? Until we have a national insurance plan where everybody gets the insurance that they deserve, I think the direct care space is filling in some of those gaps, right? So people who are already spending thousands of dollars, by the way, on their insurance premiums, can now take that cash in a very transparent way, pay that cash to a primary care physician that actually has an hour, right? Or more to dedicate just to you and personalizing your wellness journey. So I think that if there is direct care in people's, ecosystem for them to explore that, obviously look at bold direct nephrology
sure.
care.
Uh-huh.
If you really care about your kidneys, I am trying to tackle the 37 million people that have chronic kidney disease and decrease that. Now, as one person, can I do that? No, but I can make sure the model works and scale it, right, at some point. So I would encourage people to look at the direct care space. And then in terms of AI, so I talk a lot at AI conferences, and I'm empowered by it because I think it's doing a lot. I think AI can be an amazing research assistant and just gathering information, right? If you obviously you got to double check those sources, even with AI. And now they have tools in medicine too, right? Where people can really actually look up on whatever the AI platform that you want to choose to see what their, concerns are. Now, what I would say is that there are significant limitations to AI and medical information, right? And we've already seen some case reports how AI, it's called hallucinating, right? It will tell you things that are just not true. And so what I would say is that use that as your research assistant, right? Try to get as much information to make sure that you're well informed and then bring your questions to the medical space. That is how we can use AI appropriately. I think it's an amazing tool. And I speak at these conferences because as they build these AI algorithms, they're all statistical equations at the end of the day. They're all putting a ton of variables into a statistical predictive equation that's spitting out, right, some information. And so where I challenge a lot of these platforms is be careful about the variables that you put in. We saw what happened with a very small statistical equation called EGFR, but EGFR was predicting how someone's kidneys work, right? So very similar to the concept of AI. And so people are just putting a ton of variables in, and it's moving so fast that it makes me worry that if there's bias baked into any of these AI tools, whether it's a AI agent, right, or one of these platforms that you're asking, that some of that bias might get spit out into the atmosphere. So I always say, great research assistant to gather data, right? But be careful about it leading you on your wellness journey in isolation. It needs to be paired with a licensed professional for you to really be sure that that is the correct information, that you're headed in the right direction.
It sounds really exciting, but also, and we all have to be cautious. So whether you are a student in school or whether you're a doctor, I think there are definitely benefits to AI and the technology that we use, regardless of what our professions are and where we are. So, what are you most excited about as far as the future of nephrology is concerned?
Yeah, it's been a huge kind of nephrology has the innovation has been has catapulted or has exploded in the last couple years. There's now, I don't know, almost 10 FDA drugs that have been approved for not only the rare kidney diseases, which is huge, but the more generalized kidney diseases. So Ozempic, for instance, has been approved for chronic kidney disease. There's a class of medications called SGLT2 inhibitors. So JART, Farxiga, these are classic diabetic medications. All of them have been approved for kidney disease and slowing the progression of chronic kidney disease. So I'm excited that 800,000 number of people on dialysis is going to be lower and lower and lower over time. The thing is, people need to be informed about these medications and starting them as early as possible. They've been approved for all types of chronic, with a few exceptions. For instance, like type 1 diabetes, there's a recommendation not to be on Jardiance or Farxiga, right? So you have to talk to your healthcare professional. But it is so exciting that we have these medications that can delay the progression of chronic kidney disease, meaning that you will die with chronic kidney disease before you ever reach complete kidney failure where you would need dialysis or transplant. That is incredibly exciting. And I also like how, again, like healthcare is, we're seeing a rapid kind of disruption of healthcare, whether it's like the insurance, right, or the way care is being delivered. I think more innovative care is coming. So home care is big, right? Like really introducing technology into our current care, whether it's wearables or, different types of AI tools that can make that care more efficient. The direct care space we've already talked about. So I'm actually really excited in this space where a lot of people are just, feeling like downtrodden and just like nervous. Like, yes, there will be repercussions, but I think this is also a great time to rebuild things in a way that works for everybody and improves the health of everybody.
Okay. Exciting. There's more work to do.
More
right?
work to do always.
Yes, you're going to stay busy.
That's right. That's right.
Yeah. So you're a Philly girl.
Yes.
LeBron is going to Philly. He just announced. What was that, last week? How do you feel
Bron.
about that? Here we go. I love it.
Go Sixers. Of course.
Conversation.
As always.
I've learned a lot, and I'm just even more impressed by your background and the work that you're doing. And I can't wait to see what else and the impact that you have in your field.
Thank you for having me. Thank you so much. This is so much fun.
People, how they can find you if you're in your bold practice.
Yes, sure.
And also online.
Yeah, absolutely. You can go to my website, amakaeneanya.com, and that will be spelled out for all of you. So a lot of vowels. And then on TikTok, Instagram, Threads, it's at Amaka EMD. So I look forward to seeing you there. Tune in for all things kidney and healthcare transformation.
Awesome. Until next time, be well and be balanced. Bye. Thank you for joining me this week. Let's continue the conversation on social media at 1 Minute with Monee on all channels. Also, don't forget to like, follow, and subscribe to our podcast on your favorite platform. Until next time, be well.